intersect with us at different points in their life when they need us. They probably don't think about us at all if they don't need us. But they trust us and they think we're great. Actually, they think we're fine. They think we're just fine. Comments like, health inspection. They knew there was some sort of government agency that handled health inspection, but a lot of people had no idea that it was really the local public health agency that does that. So, the big takeaway for us was that, really, they're just not that into us. They think we're, again, they're fine. We're fine. We're off to the side doing our thing. I'm sure nobody could name our medical officer of health. They probably couldn't name our medical officer of health on, February 15th of this year, but we knew, all of that was about to change. So we really spent the 2 years after that research, around 2.5 years before COVID, being really intentional about engagement with people in Niagara. We invested in resources for digital engagement where previously, our Twitter, regional Facebook was kind of, side of the desk for us. The health promoters in all of our different programs would work with our communications team to develop content. But it was really, one-way broadcast communication out from our social media channels versus that two-way engagement. But we tried really hard over about 2.5 years to build up that engagement. Okay, so that fast forward to March 13th, where Niagara had its first case of COVID-19. We had been thinking, obviously, as we knew COVID was working its way towards us over a couple of months, what our communications approach would be. Luckily for us, there were other jurisdictions in Ontario who had COVID cases first. So we sort of learned from then about how to announce the first case, because that was a really big deal. We knew it was coming. So for us, we did a video with Dr. Hergy, our acting medical officer of health. We stole that idea from Peel, because I think it was Dr. Hopkins at the time who shot a little video that was sent out with the media release. But basically, we sent out the media release. We did the video with Dr. Hergy, which was his first video like that with the public. So I'm sure it was a real introduction to a lot of people who the medical officer of health was. And we basically scaled up overnight. So we weren't really set up for a call center, our COVID info line. In the 7.5 years that I've been with the region, we've done this a couple of times. When we had our measles outbreak in 2015, we did create a dedicated measles line, but certainly nothing like what we're about to face with COVID. So, we got our website up and running. Shout outs to, Tracy Haley, Tara Wincott, Lisa Bodwin, all of our Dynamite health promoters that worked with the program staff to build our website. And then over the course of that weekend, we really we got slammed. And the calls started coming in, the emails, the tweets, you name it. Everyone was getting in touch with public health, where a couple of weeks earlier, they probably, wouldn't even know how to find us on a website. So I'm going to talk a bit about communications challenges. So if you think about the title of my presentation about the noise and cutting through the noise, I'm sure we've all experienced the noise over the last several months. And at the very beginning, there was a lot of noise. So there's a lot of information coming at us from all different sources, because it's not just like, Niagara wasn't the only area dealing with COVID. The entire world is dealing with COVID. So how do we create information that is specific to Niagara residents and make sure that they're getting it from us? Because we wanted to be the go-to for COVID information. Information was changing daily, at least, if not hourly. So thinking back to the very beginning where we were creating posters. So this is when, everything was still open. You could still go out into the public, but we had these screening posters, right? So at first it was like, if you were in Wuhan, China, don't come in. And then it was Hubei province, then mainland China. Then I think it was Italy, Iran, several other jurisdictions. And finally, after a few weeks, it was just like, if you've left the country and you're just coming back, please don't come into this building. Federal, provincial, local information, trying to align messaging with the province and the feds. People don't really know us, right? So I was just talking about the research that we'd done in 2017. We'd made some strides, but a lot of people still didn't know about public health and what we did. Internal challenges as well. So I talked about how we weren't really set up for a call center. So structurally, trying to break down those silos that we always talk about in public health, really flatten the organization and redeploy staff to the COVID response. And then finally, a challenge is, this was a marathon, not a sprint. So personally, I was really struggling in the very beginning about dealing with COVID at work and then coming home. And it was like, oh no, I have to deal with COVID at home too, because this is impacting all of us. My son who's in school, my husband who works, our whole family. So previously when we'd had the measles outbreak or we had a suspect Ebola case several years ago, it was a work thing and I dealt with it at work. And then I came home and I could turn it off. So I know a lot of our staff were dealing with that and are still dealing with it. Just checking my time here. All right, I got 1 minute. Okay, so I wasn't able to, as I'm not a graphic designer, put this on a slide. I've drawn it on a napkin. This is as close as I can come. I wanted to talk about the feedback loop. So the communications team, kind of at the center, sending out messaging and taking in information, tweaking messaging, sending it back out. And that's really how we set the stage for moving forward in the beginning. And then it's how we've worked since then. So dealing with our municipal communicators, creating toolkits for them. We know that some people will call the communicator or their municipality directly. And how do we support the municipalities to be dealing with the residents? Social media, comments coming in. Oh, I'm getting a lot of questions about a certain topic. We need to update our FAQ because people are asking about fishing, the very beginning. Can I go fishing? Can I go for a walk? Okay, we're getting that a question a lot. Put it in the FAQ. Other ways incoming to public health, phone calls, emails, webmail, same thing. Staff, what kind of questions do staff have, right? They're a huge audience. Niagara Region is one of the largest employers in Niagara, right? So they have a lot of questions. And then our partners, post-secondary, secondary, media are a huge partner for us. They'll be in touch with us and saying, people are sending letters to the editor and asking this question, we need to answer them. All right, I'm at the 10-minute mark. I'm getting the hook. I will jump ahead. Basically the slide says, excellent engagement, lots of new followers. And this is my last slide. Thank you to everyone for caring about public health. It's extremely important. And I will turn it back to Julia.
Great, thanks for that presentation, Meredith. I know we already have a few questions flowing in, so we encourage you to continue to ask your questions. And now we will go to our second presenter today. So I will hand it over to Don.
Thanks so much. Absolutely delighted to be with you this afternoon, and thank you to HPO and OPHA for allowing me to be here, and thank you to Keaton for the invitation to join you today. As you can see on the screen, I'm a registered nurse with a background in knowledge translation, having previously worked at the National Collaborating Center for Methods and Tools as research coordinator of the Knowledge Translation Registry, which I'm sure many of you are familiar with. I'm desperately hoping to be able to advance my slides at this point, and there we are, able to do it. So today I hope to speak with you a little bit about what we've done in Waterloo Wellington as part of the Waterloo Wellington Older Adult Strategy to communicate with older adults, particularly those at risk of frailty and social isolation during COVID-19. I'll talk a little bit about the strategy itself, a bit of background, share a few ways in which we responded quickly to meet the needs of those in our communities, and discuss the next steps that we see in order to keep older adults safe and well during COVID-19. So the area I'm talking about is on your screen here, relatively young Lynn area, Lynn catchment area, Waterloo Wellington Local Health Integration Area Network. You can see that this encompasses places like Guelph, Kitchener, Waterloo, Cambridge, Fergus, Elora, St. Jacobs, Elmira, places like that. In 2018, we worked as a community to develop the Waterloo Wellington Older Adult Strategy in collaboration with the Research Institute for Aging. I led the development of this work, and this is the framework we landed upon that articulates a 10-year plan to improve the health of older adults and the systems upon which they rely. And we thought very broadly about this as being an intersectoral approach to supporting health, not merely the healthcare system responding. So you can see here a series of 6 goals that we landed on, and a series of key enablers and priority pillars upon which they rest. So of course, as with others, our work pivoted very quickly to respond to what was emerging in March. And we were very pleased that over the past year, over 2019, we engaged in the implementation, or the first phase of implementation of the Waterloo-Wellington Older Adult Strategy. And that had allowed us to build really strong linkages and relationships with others, and really put structures and processes in place to communicate across our networks. So we were able to mobilize a response more quickly than we would have otherwise been able to do in previous years. Of course, during this time, we were all reminded of and mindful of one of the new paradigms in aging, that's focusing on adding life to years, not years to life, is ever so important. The situation, well, as you know, trends continue to head in a concerning direction. Currently, we're worried about, and as we were in the summer, people succumbing to pandemic fatigue. Although all groups are at risk of contracting COVID-19, older people face significant risk of developing severe illness. You will all know that that is not because of their age, but more so the correlation of the advent of chronic disease to age. So on March 28th, as folks will know, the provincial government directed those aged 70 years of age and older to self-isolate in their homes after having come through what had been a long winter. Not to go out to protect them, in order to protect themselves. So older adults in rural and urban communities, this placed them at higher risk for social isolation and loneliness, thereby putting them at higher risk for developing frailty prematurely, particularly those who were living alone, and especially those who were not currently linked to services. So everyone began to, in our families, in our practices, in our workplaces, we began to wonder what older people were hearing, seeing, thinking, feeling, and doing. And it's through this that we practice our empathy in our roles. So we took that into account as we began to think about how we would respond, being that we weren't an actual health service delivery agency. We were very much a collection of partners and providers who wanted to do work collectively. We knew that older adults were experiencing intense feelings of loss, be that loss of contract, loss of connection with family and friends, loss of autonomy and self-determination, and in many cases, loss of purpose, because folks weren't able to volunteer in places or worship in places that they normally had. And that many have experienced loss of life and were feeling grief and were grieving the loss of others, not the least of whom perished in long-term care homes. So it was important for us to think about how can we get messages out on promoting health and well-being, and you would know all of these during COVID-19, so that people didn't become consumed with the signal to noise ratio that we just heard Meredith talk about. Lots of information coming, huge volume of information, overwhelming, sometimes unclear, and often not credible. So how could we be helpful in getting the message and words out to older adults and their families? What actions did we take? Well, we worked to coordinate a collaborative response to the COVID-19 pandemic by advancing a multi-level engagement plan with the understanding that broadband capacity was limited in rural communities. In our early days of developing the strategy, we heard from older adults living in rural communities that they preferred to receive information through their free local newspaper delivered to their homes every week in a way that was something that they could look forward to or know when to expect it. So we began to mobilize our campaign. This multi-level engagement plan focused on 4 different areas of engagement: conventional media, which is what I'll talk about mostly in this presentation. Social media, so we used Caregiver Connections Waterloo Wellington, a new Facebook page that had been put together here by our group to support working caregivers, and several other rural township and town Facebook pages. Community engagement, how do we directly engage our community, and how do we engage our existing networks? So the intervention really that we're focusing on today was an outreach, a regional-wide outreach and social marketing campaign to mitigate the risk of isolation and frailty to older adults, particularly those over 70 years of age. There was an imperative to be respectful of what was currently underway and who was leading in what areas. And we wanted to be very intentional about adding value to what was currently going on, not interfering with great work underway. Collaboration was key, so too was the need to mobilize swiftly. So we developed a campaign called Stay Safe, Lead the Way with our partners. We began in the rural communities immediately during the week of April 7th with a network of local providers that tailored information that was centrally curated within their local newspapers. So we purchased ad space, we wrote articles, and we had a very deep engagement from community members in the co-design of this project. Here is the collection of women who live in, this is a picture taken in Fergus, I'm sorry, or is it Elora? It's Elora. And where we gathered to meet and for a photo opportunity for an article we were doing. But these are regular women living in Elora, very much helping to shape the messaging and the themes that we carried forward. So the goals of our campaign were to provide older adults with credible information to stay safe and healthy during COVID-19 and beyond. Point older adults to local services and supports to help them access what they need when they need it, because there was a lot of service disruption, as we know. Help older adults cope through these times by sharing hopeful, positive, and strengths-based messages, encouraging older adults to maintain a healthy balance of activity and routine, and enable older adults to experience a sense of empowerment even during these times. The key themes we have been running with since the week of April 7th were staying safe, keeping active and connected, taking care of your mind, body, and soul, that holistic approach to care or to life, accessing care and support services early, and finding joy while staying positive and hopeful. Some of the sample messages we offered are listed here. You'll also see those in a series of ads that I'll just flow across the screen. While being worried is normal under these circumstances, being consumed by worry and fear is not. There are healthy ways to cope with these feelings, and we would share those ways to cope. Staying connected with family and friends while practicing physical distancing was important, and we shared ways in which they could do that. Reaching out for help if you need it by talking to a trusted family member or friend and seeking care if you're experiencing a sudden health problem that you believe needs to be examined by a doctor. And beginning your day and ending your day with hopeful and positive thoughts, and minimizing the amount of media you're consuming, and taking time to listen to the music and perhaps dance. You're never alone. There are people to help. It's safe to reach out. These were some of the key messages we carried. Here is the first week's ad that we went out with. And this, for the first few weeks, we were telling people what not to do. And this relates to grocery shopping. So have someone else pick up your groceries. Don't go out if, etc. Trying to impress upon people the risk involved. We then pivoted to here's what you can do, and letting them know that they have an important role to play. Older adults have faced adversity in the past and often thrived in the end. So how could they model the way for their community? So we're giving some examples here of how you might focus, instead of focusing on loss, how you might focus on opportunities to find joy. Here's the message: turning off the radio or the news and dancing like no one's watching. In fact, it had never been easier. Here again, you can see there's a health education emphasis on the risk of not staying mobile and reducing your activity in terms of the loss of muscle mass, and trying to educate and cheerlead and support and give information on what people can do. This is an ad that's run several times throughout the course of the last few months. You in your area may be hearing stories of older adults showing up in emergency departments in particularly frail and deconditioned health. So the notion here is to, even if you don't need your doctor now, make sure you know how to get a hold of your primary care provider should you need them, and don't put off reaching out for help. Well, here we have a quote from one of the local physicians in one of the rural areas. Again, here we're pointing people to resources that they can call if they're experiencing mental health challenges, and other activities that people might participate in, virtual activities such as the Without Walls model that had increased over the course of COVID. Doing what makes you comfortable and safe here is a bit of a decision support tool for older adults. If they're thinking about going out into their community as communities were beginning to reopen, they could ask themselves some of these questions to make sure that they're ready to do that, because many weren't. Many were very distrustful. Doing what you can and need to do to age well in the community. So we knew that people were wondering if they would see their children again their grandchildren again once they returned to daycare or school, etc. And some of the questions that might be on people's minds, but trying to encourage them to take some of our key actionable messages to task, really wanting people to know that they mattered. One of the most important things we hear is that it's important to let people know that even during these times, they matter. During Seniors Month, we expanded or intensified the campaign with funding from the United Way, Guelph, Wellington, Dufferin, and the United Way Waterloo communities, Waterloo Region communities. We had funds to go and do television ads, television interviews. We mobilized a speakers bureau and a writers guild to craft articles. We had radio ads that were purchased and radio interviews that were we got through a media alert, a media release, and with support from the Region of Waterloo Communications team, who lent their expertise to us. We didn't have expertise in media engagement, and they did. We had a number of ads and articles go out. What's next for us? We've applied for further funding to use all of the many created ads that we have and move them into a print format, and engage local organizations and agencies to deliver these to the people they're seeing, whether they be delivering meals, whether they be providing in-home services, sending out invoices or newsletters to people who would benefit from receiving this information. So we won't be directly contacting people, we'll be moving through the community-based service providers, but this will all be centrally tailored. The ads will be tailored to their local service. They'll be printed centrally and distributed to those agencies. Even thinking about groups like pharmacies, audiologists, denturists, churches, service clubs. We presented to the Rotaries. They're very engaged on this and wanting to know how they can be helpful, and other groups. One example of a way in which we flipped this a little bit. So instead of pushing communication out to people, we wanted to be mindful on how we can support those who were struggling during these times. So we offered our empathy. We put a little bit of wind in the sail of some older adults who were spouses of residents living in long-term care homes. And they were feeling a real sense of harm and trauma by the visiting restrictions that had been put on long-term care homes that you're all very familiar with. And we wanted to help them articulate what they were feeling to decision makers. So I supported them to develop an impact statement and a companion position statement. And that has been very helpful, allowing them to feel empowered in a time when they felt hopelessness and helplessness. We're now expanding our messaging across Ontario Health, West Region, with our colleagues, and trying to mobilize and amplify some of the messages we've already created. The great work has already been done. It's just about moving them in different venues. I won't speak too much about this, but we're moving forward with invigorating the Gatekeeper program in Wellington and bringing it to Waterloo. Some of you might be aware of that, but it's about engaging community members on how to be mindful of and aware of older adults who may live in their neighborhood or who may receive service from them, on how to spot someone who might be in trouble or earlier, or might be experiencing a need or frailty and need to connect to services. So I'd like to make the final acknowledgements, and then that will be the last of me. To the United Way Guelph Wellington Waterloo Region communities through the New Horizons, through the Emergency Community Support Fund offered by New Horizons, the federal group. Community partners that we worked very closely with and continue to work closely with, the community members of the Waterloo Wellington Older Adult Strategy who serve as a sounding board and a reference group and true partners in the co-design of the work we've done, and to the Region of Waterloo communications team. Thank you. I look forward to the discussion.
All right, thanks for that great presentation, Don. I know we had lots of questions come in through the question and answer tool, so we'll have opportunity to discuss later. Right. I'm now just going to pass it over to our final presenter here, Janine. So go ahead.
Okay, I'm trying to share my screen and let me see here. Hopefully this is going to work. If not, I only have one slide, so I may just speak to it because I know where. Let me see here. Can everyone see that?
There we go. Great. Thanks.
All right. Awesome. All right. Just give me 2 seconds here. Okay. All right, so thank you very much for the invitation to be here, and thanks to Keaton for organizing this and everyone that's been involved. When I started developing this, it was 8 months in. Now I think we're 9 months in if you count from March, so I'm sure there's 9 lessons I could talk about, but also I'm sure 8 months from now it'll be a whole bunch of new and different learnings. I am going to be reflecting on my time as leading communications at Lake Ridge Health, which is one of Ontario's largest community health systems, and now at North York General for the last about 2.5 months, where most of my time has been focused on pandemic response. So I just want to back up. Early in March, we thought really that all thought that this was a travel-related virus. We didn't know how infectious it was. We didn't know how severe it was. And we really all of our efforts and our communications were really focused at least in the organizations that I was part of and the systems that I was part of, was on calming the seas, managing what we thought was a very specific set of risks, and really carrying on as business as usual. We were wondering, should staff travel? Where can they travel to? What about quarantine when they come back? What about March breaks? These were the things that were on our minds. But then March 11th happened and the WHO called a pandemic. There was a first death from a community transmission in Ontario. And then the following week, there was a state of emergency in Ontario. And then within that week, something unthinkable happened for hospitals, in that we stopped providing most surgeries, closed down ambulatory services, did not allow visitors. We basically ceased to be full service hospitals and really focused on just emergencies and the care for the seriously ill. And we started to see people coming into our ICUs and medicine units with COVID-19. So everything changed, and within weeks, that meant our whole communications approach was blown up, and we were dealing with a pace of change that I think it's completely unprecedented for most of us, at least for for a prolonged period of time. So I'm going to go over the 8 lessons, and then I don't have a lot of slides, just really want to talk through what each of them are. So the first one is not over relying on conventional emergency and crisis communication planning. It is good to have a plan. It's great to have tools and principles, and they have stood us well. I mean, we could rely on lessons learned from SARS and more recent pandemics, but really we needed to really rewrite the playbook, and are still kind of continuously rewriting the playbook as we go along. And we have to learn to be comfortable with a different approach to emergency planning, which is very adaptive and agile and about learning as we go. The usual arc of a crisis does not apply in this case. And so we're dealing with a crises within a crisis that has these continuous waves, and we're not even sure how many phases or for how long. So one of the things I was reading about that we didn't anticipate was in the pandemic planning in Canada was the impact of pandemic fatigue. And certainly I know that is a new challenge that we're all dealing with as communicators. The second lesson is that change happens at the speed of trust. You probably know, I've heard of that book and that saying, of course, but it really does ring true when it comes to COVID-19. So really, first of all, understanding the context within which COVID-19 happening at a time when we're all aware that there's widespread distrust in institutions and governments and science and experts, and a lack of a cohesive common set of truths, and a kind of a growing trend of people kind of seeking certainty and simple answers, and populism and all those things that we know are going on makes it very hard to communicate fact-based, science-based messages. That's a whole massive topic unto itself, but it's really critical then that we must communicate with people, and that's where trust becomes even more critical. You know, I think the majority of people try to follow the practices, do what they can do their part to keep the collective safe. And they're not willfully flouting the rules, but they are tired and skeptical. So transparency is absolutely key to trust, but not just transparency, putting information out there, but it's actually explaining the why, and the making sense or sense making has been absolutely critical. So communication strategies and people that can actually make sense, while breaking down the explanations, connecting the dots for people, simplifying things but not talking down to people, will be your most effective communicators. One example is when within the healthcare system, explaining to people the approach to PPE precautions, and that we knew it was spread through droplet transmission. And so we need to be able to explain when we know something and once something has been established or evidence, but also be clear when we don't have all the answers, what we know, so people can distinguish between what is known and what is not known. And key to trust also is humility. Needing to admitting when we don't have all the answers, and maybe when we are changing our decisions because we've learned new information. Some of the most effective leaders throughout the pandemic have been people that have had confidence in what they're saying, but also acknowledge that we are still learning as we go. And I think that's hard because people do want that, crave that certainty. And again, having effective messengers, not just the message, but the messengers. People need to hear consistency from the experts and people they can trust, but they also need to hear from those community leaders, those informal leaders, people that different communities trust, need to all have kind of the same kind of messaging and information, whether they're faith leaders, family members, really need to understand who are the trusted messengers for any given community or group. The next one is coherence is key. So in the first wave, there was a lot more coherence of messaging because it was probably easier. We were all kind of in shock. There was, I think a lot more trust and you know, reliance on government at that point, and people really clearly mobilized around what they needed to do. Not everyone, but most people did. But with the second wave, there's certainly a lot more disillusionment, fatigue, as we mentioned. And so, and there's different opinions that are coming to the fore. As we're transparent, people are seeing how decisions are made and they realize it's not messy and there is conflicting opinions. So I think now is the time for, you know, leaders to look at how, as we work out strategy behind the scenes, how we try and come up with some better coherence in the message, and really also explain when we need to take regional or targeted approaches, why there's differences sometimes, and explaining those in a consistent way. Fourth lesson is communicating with compassion, as people have talked about. The measures that we need to take seem easy, and I think everyone pretty much knows them by now, but there is frustration, and it is very hard sometimes to do the things we're asking people to do, even though they may seem easy. Being isolated from each other, being not able to, you know, being not able to see your colleagues in person without their mask. All these things are really very hard for people to do over time. So we need to understand where people are at. And also we can learn from, there are some things we can learn from past public health experiences like the HIV/AIDS epidemic in the early years. We learned that lecturing, blaming, and so on did not work very well. It really served to alienate and stigmatize people. But we need to learn about empowerment and also, you know, supporting people with their own, giving people their own agency to do the right thing. And I think we can look to effective leaders and communicators who have used compassion very well, have identified with people while still being clear and pragmatic, like Bonnie Henry in BC, obviously, New Zealand's Prime Minister are two that come to mind. Other lesson is messages and communications without action will ring hollow. If we're asking people to do things and make sacrifices over a long period of time and change it, and that change, we need to enable them to do the right thing. So I think coupling policy changes and structural changes and supports with the messaging is going to make your communications stick and help people change their behaviors. For example, knowing where, is there a reason why people may be coming to work with symptoms? What are the barriers? Is it economic insecurity? What is it that will help them, support them to stay home when they're ill? We found at North York General that we had a few outbreaks over the last couple of weeks, and they were staff-to-staff transmission, and they were largely people coming to work with symptoms and not identifying that they had symptoms, or in break rooms and lunch areas, taking down their guard, not wearing masks and not adhering to social distancing or hand washing and all those measures. Well, we realized that we were asking people to physically distance, but the lounges and the break rooms were not conducive to social distancing. And it wasn't always easy for people to go down 6 flights of stairs or on the elevator to get to the cafeteria during a very short break. So what we did was a very practical thing. We looked for areas where we could expand lounge areas, create inviting, comfortable meeting spaces where people could socially distance. So there's those practical solutions. So once we did that, they were a lot more open to the messaging about doing the right things and the precautions. Number 6, cardinal communications rule, know your audience, but customized communications is clear. While on the one hand, we need consistency and coherence, we also need to understand what's going to motivate behavior change of different groups. In the first wave, fear was a big motivator for a lot of people, but now I think things are a lot more complicated, and we need to understand where different groups are at emotionally, what are the things that are going to appeal to them, but also how we need to deliver the messages. If we're asking people to be socially distant in their communities, that's a lot different if you live in a house and you work at home, rather than people who maybe live in highly densely populated communities, multi-generational families like Thorncliffe Park or in Peel. So we need to have pragmatic messages that meet people where they're at. One of the things we did at Lake Ridge Health was we met with ethnocultural leaders and faith groups early on in March to find out what they need, what their community needed, what kind of information. And they were saying a lot of their community members worked in food services and restaurants, but were not getting the messages about what to do, how to be safe in those at work. And we found that because it was very simple, they weren't tapping into the community media channels or the social media channels where we were delivering our messages. We need to get our messages directly to the community leaders, directly to the community-based channels that they know and trust, and also simple things like making sure that the messages were available in a timely way before they became outdated in multiple languages. So that's some simple things we did that made, I think, a world of difference in people's, being equipped. I think I'm pretty much done. 7 is just, there's been a lot of criticism about the communications coming out of not only Ontario, but lots of provinces. And I think as a communicator, it always is oftentimes the communications are a symptom of maybe the policies and the ideas not being clear. So part of this is that we are seeing the sausage making of science, that it isn't always clear as we work through problems in public, but we also need to maybe take a step back and understand the root causes of the confusion. Maybe there isn't policy coherence, and maybe that is, with that clarity, it will help with the clarity of communications. And lastly, is ending on a positive, hopeful note, is that obviously we've proven an extraordinary ability to take collective action together. If we think of all that we have done in such a short period of time, the problem solving, shifting services onto virtual care and really supporting people well and in a way that sometimes they prefer, the speed of vaccination. We've seen nothing really like this in modern times. So our challenge in public health and communications is, how do we get that kind of burning platform? How do we get people kind of collectively motivated again on a mass scale, creating the hope, but not false hope? And, really tapping into people's better angels rather than their, self-interest is going to be really critical at this time. So thank you very much again, and look forward to the dialogue.
All right, thanks, Janine, for that. We're actually going to just go right into our questions. I know some are being answered currently, and then some we'll have time for today. So one of the questions that came up, which you all kind of touched on a bit, was just how important it is to be consistent in your messaging, and how do you actually achieve this when the evidence is always changing? So anyone can answer this one. I think it's applicable for all our panel. Yep, Meredith, go ahead.
That's a good question. And it is really challenging, especially when the information is constantly changing. So for us, it's just really important to stick to the same principles that we've used throughout around transparency and being consistent, and running everything through our medical officer of health. He's very connected, our acting medical officer of health, very connected with other MOHs and AMOHs around the province. And so they're often in alignment with their messaging. So yeah, it's extremely challenging. And like we said, it's changing hourly, daily, weekly.
All right, so we'll go to another question. I know there was lots of questions around the older adult strategy that you presented, Dawn. So one of the biggest changes during COVID has been the shift of social connection to Zoom or to other online platforms. Folks say they've struggled with how to engage isolated senior adults who are not tech savvy, and if you have any strategies in specific to engage seniors.
I don't know if they'll be as concrete as you're looking for, but we have identified, it's a three-pronged approach. Do people have the devices or the hardware that they need to connect? Do they have the connectivity, so the broadband or the bandwidth? And do they have the digital literacy to operate these devices and new platforms? We've been working with the United Ways to try and approach that from those three levels. There have been a lot of emergent virtual connection opportunities for services. So adult day programs, which would usually be attended by older adults or people with dementia, they were a great place for people to go and receive activation and spend their time, offering lots of respite to their spouse or caregiver. Those are now being done online to some effect, not full effect, but I think you'll find that the libraries and others and services have adapted to better support people with onboarding to that virtual platform or virtual technology. That's been helpful, but that's been homegrown.
Great. So another one that came up, which is a bit related, but it's for Janine. So folks found that communication via social media wasn't reaching marginalized communities. Did you have a strategy for packaging and distributing information to marginalized communities?
Yes, I think that one of the things that we did at Lake Ridge Health was, again, bringing together the leaders, the informal and formal leaders for different communities. So we had what we called the community leaders group, but it was really all of the major faith-based, ethnocultural, other communities, LGBTQ, like whatever the different communities are, and actually co-created with them. You know, so what are the best ways? It was very practical, actually. It's just was getting the messaging packaged and out in a timely way. One of the other things was because of the fast moving pace of this, we needed to have nimble ways of getting the information. So a lot of it was just providing the content to groups, and then they repackaged it in whatever way, shared it on, you know, virtually or in their own newsletters, or in, you know, if they had online congregations through, you know, I think we were encumbered in terms of the personal, obviously gatherings weren't an option there. So there was a lot of use, and telephone, because the telephone town halls, telephone means are, I think, you know, a great way to reach everyone, because everyone has a phone. So those are some of the ways we overcame that.
So another question that may be applicable to all of our panelists, but it's around data. What types of things were you looking at in data to actually see if your communication strategy was effective?
I can comment on this, on the campaign, at least, or the multiple ways in which we engage different groups. We looked at those from a different evaluation perspective. We could really only look at the reach we were having with the community and the proportion of older adults we were targeting within those communities, knowing the distribution of the different media channels. We've had a lot of qualitative data, anecdotal data come back, agencies having received phone calls left on their answering machine saying how much people appreciated. And in one situation, a woman was tearful as she was conveying how much she appreciated seeing those positive messages every week and looked forward to them. So really, I don't have anything as concrete as you'd like.
Any other comments around this?
Well, I'll just comment. You know, we put probably equal, if not more, emphasis on internal communications, because especially during first way ongoing, because we really had to, during the emergency, really get our people on board and support them in their role and adapting these new practices and ways of working. So what we did do some evaluation internally, and we did, it was just basically a simple survey, but we really wanted to get at from people, are they getting the information they needed to do their work? Are they getting it in a way that's meaningful to them? What about the frequency? You know, what, and from that, we actually changed something, the way we did things. So we had an intranet that people could not actually access through their mobile. Like, they had to go onto a VPN, which was not nimble. People could not, you know, get the information they needed in real time. So then we created a SharePoint site, a brand new intranet within basically days, an info site, which was very well received by clinicians and all teams, and was kind of the go-to hub for the latest information and tools. So, you know, I think that was, we built a lot of confidence because we actually acted on what people were telling us would work.
Well, we have about 2 minutes left. So unfortunately, I think that's all the questions we're going to get to today, but I did see that panelists were responding to some of the questions via text, and I'm sure that you can reach any of the panelists with additional questions. So now I'm just going to share a little bit about our next session, which will be our last. Let me share my screen here so that everyone can see it. Sorry, that was the, let's just flip to the last one here. Okay, perfect. So then our last session is going to be around addressing inequities during a pandemic. We have actually 4 presenters with us for that session. You can see there Zoe Dodd, Kim Perota, Dr. Jennifer Rayner, and Dr. Ahmed Bayoumi. So we really do encourage anyone to attend next week. It will be at the same time, so Thursday, 12 to 1, and you have the link there where you can actually register if you haven't yet registered to attend this session. So a big thank you to our panelists today. A thank you to our planning committee. We really enjoyed the session, and I'm sure there's lots more questions that we'll be getting, so we'll be sure to pass those on to you as well. Thanks everyone for joining us today.